Hello everyone, can you guys hear me? Those who are in the Zoom? Okay everyone, so thank you so much for waiting for 5 minutes. Again, let's start our class tonight. So first of all, again, let me welcome you to First Aid AMC MCQ. I think you enjoyed our previous session on psychiatry. If any one of you have missed that class, that's a vital class for AMC MCQ because psychiatry may give you a little hard time in the exam because as I always say that all the medicine, surgery, gynae, obstetrics, pediatrics, we know a little bit, but psychiatry usually we don't used to read this much in our medical universities or any others classes. So thank you so. So that's why it's pretty important to have a good idea on psychiatry. Our initial class, the first one, which we took in 10th of May, was based on psychiatry basics. And tonight we are going to do some of the sample questions that sometimes can be similar to the exam, like the pretty similar topics, and we will discuss those questions so that you know how to get the questions, how to get the traps of the exam questions, because in the exam everything in the questions that are given are there for some reason. So you have to find out, is it for giving you some clue to the diagnosis, or is it just to give you some trap so that you fall into the trap and then you just choose another incorrect answer. So very important to find those tricks. That's actually the important thing, to do some of the sample questions related to the exam. We're going to do some very important topics. Usually always these are very high yielding for any exam. So let's start. If you have any difficulty with any of the questions, feel free to ask, because tonight class will be a little harder topics. So I think like many of you are just a beginner, but I want you to understand that your AMC exam is not for like that they say that it's for a junior doctors, but usually sometimes exam question comes as a very difficult some of the times. Most of them are pilot questions, but still, who knows, it can be scored anytime. So very important to know how to do those questions, and if these topics comes in the exam, how to crack those questions. That's very important. Don't worry, I will let you understand that how you can pick up very tiny clues from the questions, and you will see that how important and how easier it becomes. So our first question is about the fluid management, very high yielding for the exam. If you see this question, let me just, yeah. So a previously fit 55-year-old man has undergone an emergency right hemicolectomy for a perforated cecal cancer. 2 days after the operation, you note this on the fluid balance sheet. So you have to find out what's the input of the patient and what's the output of the patient. So you see the input is 2 liter. So you have given 2 liter fluid to the patient, and what are the output of the patient? If you look at here, nasogastric aspiration is 2 liter here. Then your drain losses is 700 ml. Then you see the urine output is 500 ml. So how much output is here? 2 liter plus 7 plus 5 is 1.2 liter again. Now, remember one thing. Just let me finish the question. So biochemistry shows these are the things. Which of the fluid balance regimens below you will order for the next 24-hour period? Let us explain. So explanation, you will find out what's the input in this patient, 2 liter. And now you have to find out the output. Output, you find out nasogastric aspiration 2 liter plus there is 700 ml plus 500 ml. Now, if you see this question, 700 is drain loss and urine output 500, right? Remember, in any output, there we actually always add another 500 for insensible loss. It could be through sweating, sometimes through feces. So any time which we cannot see, sometimes evaporation of heat losses from the body. So this 500 is called insensible loss that you cannot see. So now if you do the math, it's how it comes. So it's around 4 liter, right? Just always keep it as a whole. It's in here, if you measure it like it's 3700 ml, but just keep it as a whole as 4 liter for the purpose of easier mathematics. Now, this patient input was 2 liter, output was 4 liter. How much deficit is here? 2 liter, right? So 2 liter is deficit fluid in this patient. Now, if you want to give fluid for a 24-hour period, any postoperative patient normally should get 1 liter normal cell line plus 2 liter dextrose. Another one is plus 20 milli equivalent of potassium. Sorry for the handwriting. It's pretty hard to write here. So 20 milli equivalent of potassium per liter of fluid. So in every liter of fluid, you have to give 20 milli equivalent of potassium. Now, this is the maintenance fluid for any postoperative patient. But in here, you have 2 liter deficit, which you have to fill in here. How you can fill in? So we usually fill in by giving it as a normal saline. So if you see here, there is already 1 liter. You have to add another 2 liters. So 1 liter plus 2 liter comes as 3 liter of normal saline. Your 2 liter dextrose will be there. Now, how much potassium you will give, guys? So how much potassium this patient needs? What do you think if you do the math? Good, Dr. Oshim, very good. So how it becomes 100? Because this patient, we will give 3 liter plus 2 liters, so 5 liter fluid. Now, as I said, for 1 liter, we have to give 20 milliequivalent potassium. So for 5 liter, how much? 5 into 20 equal 100 milliequivalent of potassium. So this will be the fluid management for the next 24 hours. Clear? So what you have to do in these cases, you have to find out what's the input of the patient, what's the output of the patient, and then find out if there is any deficit. So in here, we have found there is 2 liter deficit in this patient. Normal patient should get a 1 liter normal saline plus 2 liter dextrose plus 20 milli equivalent of potassium every liter of fluid. Our patient has 2 liter deficit, so we have to add the 2 liter in this maintenance dose. So we usually give it by a normal saline. So 1 liter and 2 liter, so becomes 3 liter normal saline, 2 liter dextrose plus. Now for 1 liter, we give 20 milli equivalent potassium. We are giving 5 liter fluid to this patient in total. So for 5 liter, it will be 5 into 20 equal 100 milli equivalent of potassium. Now, if you go back to the questions, what's your answer now? You have got your answer, right? So it's number D. So 3 liter saline, normal saline plus 2 liter dextrose plus 100 milli equivalent of potassium. Clear, everyone? Any question? Those who are in the Facebook, you can write it in the comment section so I can see them and I can answer you. Great. I think everyone got it. So next, move to the next question. The next question is another important one. So this is actually from infectious disease. If I ask you which one is the most important infectious disease question that can come in exam, always tell me that it could be the difference between HIV and infectious mononucleosis. Very, very important, very high yielding. You have to find out how to differentiate between HIV and just a normal infectious mononucleosis. Pretty hard to differentiate just by looking at the symptoms, but some of the symptoms are exclusively for infectious mononucleosis. Some of the symptoms are exclusively for HIV. Look at the question. Patient comes back from Thailand with history of having sex with multiple prostitutes. Looking at this line, it seems like it should be HIV, right? After 1 week, presence with lymphadenopathy, mild pharyngeal erythema, splenomegaly, sore throat. There is atypical lymphocytes present, but monospot test is negative. What is the diagnosis in this case? Now, if you look at this multiple prostitution, so obviously there is unsafe sexual practice. So if you are just a normal candidate, you will immediately go for HIV. But no, this is the exam. They usually don't give you this much, like pretty clear-cut things. You have to think, you have to justify what you are answering. So now go for the symptoms of this patient. Lymphadenopathy can be there in HIV, can be there in Epstein-Barr virus. Before we discuss the symptom, let me just show you this chart from your JM, which is very important, and this will help you to find out this case. So HIV and EBV, how to differentiate? Usually, both of them can present with a fever, fatigue, malaise. These are pretty common. Most important finding in Epstein-Barr virus is the tonsillar involvement. So there will be tonsillar hypertrophy, and there will be obviously sore throat with the exudative pharyngitis. It should be there if you think someone has a Epstein-Barr virus infection or infectious mononucleosis. So first thing, sore throat with exudative pharyngitis, pharyngeal erythema, that should be there. Mucocutaneous ulcer is not a feature of Epstein-Barr virus, but it's a very common feature of HIV. Oral ulcer, very common in HIV. Now, mild enlargement of the tonsil can be there in HIV also, but exudative pharyngitis is very rare in HIV. So that's usually, it's one of the very important clue. You should find it in the exam. Skin rash. Rash in Epstein-Barr virus, usually it comes after giving antibiotics, but the primary viral infection causing a rash is pretty unlikely in Epstein-Barr virus. So if I ask you Epstein-Barr virus, how many types of rash it can cause? It can cause two types of rash. One is primary, another is secondary. Primary is the virus causing the rash, which is very unlikely for Epstein-Barr virus, but HIV, pretty commonly it can present with a maculopapular rash in whole body. But in Epstein-Barr virus, secondary rash can appear if you give any patient comes to you with a sore throat and you, by mistake, you have given augmentin or amoxicillin. The next time patient presents to you with a maculopapular rash. What is that? That's usually very common phenomenon. If any time in a Epstein-Barr virus patient, you give augmentin, amoxicillin, patient usually presents with a secondary maculopapular rash. What's the treatment? Stop the amoxicillin, nothing else, and the rash will be resolved. So never ever give amoxicillin augmentin to any patient with sore throat. A patient comes to you with a sore throat, what will be your treatment? If you think that it's a tonsillitis and you want to give antibiotic, your choice of antibiotic should always be phenoxymethyl penicillin or penicillin V. Never ever augmentin. Clear? Now, Come to the main point. Jaundice is not a feature for Epstein-Barr virus or EBV. Diarrhea, not very common, but HIV can come with a diarrhea. Cervical lymphadenopathy, it's common in both EBV and HIV, so it will not help you to differentiate. Splenomegaly, another important one for Epstein-Barr virus. Usually, Epstein-Barr virus, about 50% cases, they present with splenomegaly. HIV, pretty rare to get a splenomegaly. It can get, but not very common. And both of them can have atypical lymphocytes. Sometimes we do a test called monospot test to diagnose Epstein-Barr virus, but it's not highly a specific test. It doesn't mean that if any patient's monospot test is negative, they cannot have Epstein-Barr virus infection. So even if monospot test comes negative, the patient can have Epstein-Barr viral infection. Now, I guess you guys understand that the main difference between Epstein-Barr virus and HIV will be sore throat, exudative pharyngitis, and splenomegaly. Now let's find it in the exam question. So if you see, this patient has lymphadenopathy, so it could be HIV, could be EBV, we don't know. There is pharyngeal erythema with a sore throat. So that's very important for EBV. Now, again, look at splenomegaly. If you get splenomegaly with sore throat with lymphadenopathy in a patient, what you should think about? Monospot test is negative. Does it exclude EBV? No. So still, we can think it as a EBV. We can think as a HIV. So what do you think from the discussion it should be? That's my question. Good. EBV, right? So that's usually, it should be a Epstein-Barr virus infection. You guys are correct. That's a very good thing that you guys are getting me. So this is our answer, Epstein-Barr viral infection. Clear? So see that if in this case, the patient would come to you with a 1-week presentation of lymphadenopathy with just a mild pharyngeal erythema, oral ulcer, you would think it as a HIV, right? So that's important to find out. They can omit the splenomegaly and sore throat and put oral ulcer here. And now if you just memorize the questions like this, and you just go for the EBV in the exam, then you guys are pretty wrong actually. So don't do that. Always find out what's given in the exam question. Always try to justify what you have read in throughout your preparation time. So it could be, always remember, in the exam, it could be anything. So you have to justify whatever you are answering in the exam. So anything like, you just need to remember the symptoms of EBV and HIV, then it will be good. So others like cytomegalovirus infection, usually if you look at the CMV, they also comes with fatigue, but pretty uncommon to have a sore throat and tonsillar hypertrophy. So already you can exclude it by that, right? So it's not a CMV. Hepatitis A usually doesn't come with a splenomegaly, rather it should come with hepatomegaly. And usually they should not come as lymphadenopathy or sore throat. So it's unlikely. Ross River fever, always they will give it to you that a patient goes, well, there will be a travel history to the Queensland, followed by patient comes to you with a fever, rash, and polyarthralgia. So what's the triad of Ross River fever? Fever, rash, polyarthralgia. Sometimes there can be lymphadenopathy. So it's unlikely in this case also. Our next question is a similar thing, just related to the previous one. So now you look at this question. A man comes back after a short trip from endemic area for only 5 days with a severe jaundice. There is fever. On examination, you find out tender liver and enlarged 5 centimeter under the costal margin. You have done some investigation, which you have found as very high ALT, AST, GGT, ALP. So all the liver markers are elevated. There is jaundice, there is a travel history, there is fever, and tender hepatomegaly. That's the most important clue. What's the cause of tender hepatomegaly from these 5 options? Okay, Dr. Oshim asked, so, but whatever about the deficient potassium? So, yeah, you were giving potassium to this patient, right? So even if it's a deficient, like 3 millimeter, that 3 millimole, the potassium that you are given, that will cover that deficiency. Think very clearly. Now, first of all, let us exclude few of the options. That's if you are confused about something in the exam, try to exclude first. Now, I'm confused here which one to choose. So I'm going to exclude the other unimportant options. Starting with the choledocholithiasis. So it's a stone in the bile duct. So a stone in the bile duct usually should not cause fever, and usually should not cause fever unless it's a cholangitis. So if it was cholangitis, I could think about it, but choledocholithiasis, just a bile duct stone, should not cause fever. So this is out. That's all right. Infectious mononucleosis, jaundice is very rare. So we don't think infectious mononucleosis in here. Viral hepatitis B. Hepatitis B, usually they should give you some risk factor. What are the risk factor of getting hepatitis B? Not a travel history. Important like a blood transfusion, IV drug abusers, or even like homosexual men. So usually sexual or IV drugs or blood transfusion or needle, tattooing, occupational exposure should have some blood to blood transmission. So it's unlikely in here also. Now in between A and C, we are confused. So which one of A and C causes tender hepatomegaly and usually presents with jaundice and fever? So pretty easy to find out. Usually, obviously, viral hepatitis A should be in our first thing in our mind because there is a trip history that's important. Maybe they have taken some contaminated water or food outside that can trigger that. The next thing is presence with fever, jaundice, and a tender hepatomegaly. Malaria patient can come with a fever, but usually chronic malaria causes hepatosplenomegaly, not a acute malaria. Very unlikely to have hepatomegaly in acute malaria. Chronic malaria presents with hepatosplenomegaly, that's all right. And also, for malaria, the liver is not a tender. The tender hepatomegaly, if we go down here, so look at the causes of tender hepatomegaly in here. Tender hepatomegaly, very important cause is viral hepatitis, CCF, liver abscess, and enteric fever or typhoid fever. So most important is viral hepatitis, CCF, and liver abscess. All right. So in this case, like if you're, yeah, Dr. Oshim is right. Like yes, like it's not like that malaria cannot present with jaundice, but it's not a common one. In between A and C, always like if we are confused between choosing one option, we have to think that which one is the common presentation. Now, if we think is as a common one, it should be like a viral hepatitis A, should be always like a, there will be jaundice, there will be tender hepatomegaly, and there will be fever. That's a pretty common presentation for viral hepatitis. Malaria, it could be, but just because we have two options, we have to choose the best option possible. So in here, it's a better option to choose is this one, the active viral hepatitis A. Clear? Any question from here? So this is from your JM, like if viral hepatitis, how it can present? It can present with initially fever, anorexia, nausea, vomiting, followed by there will be hepatomegaly, sometimes splenomegaly, sometimes there can have some dark urine, pale stool also. But it's pretty common in obstructive jaundice to have a dark urine, pale stool rather than viral hepatitis. Now, endemic area, like we don't know like what exactly it means by endemic area. So endemic area, it could be endemic for hepatitis, it could be endemic for dengue, it could be endemic for malaria. So we don't know like actually like what it means by endemic area. The next question. So we have finished two important questions related to infectious disease. Very important. In the exam, it becomes very hard because it's so confusing to choose one. Like you see that it's pretty easy to exclude three options, but hard to find out the exact one. Between malaria and hepatitis A, it's very hard to differentiate from that question also. So always look for any clues in the exam. If Now, in this question, in the previous question, if there was a fever with chills, we would think about malaria again because fever, chills, more commonly malaria. Usually, your viral hepatitis would not never ever give you chills. So just if they add chills with the question answer becomes malaria. So it's pretty important to find out the clues, look at the questions very clearly. The next question, scenario of a patient with fall from the bicycle 1 week ago, and there is a helmet fracture. Whenever there is some head injury, look at the time duration. So it's a 1 week ago. So it's a kind of subacute presentation, not an acute presentation. That's a very important clue. It was pretty hard because there was a helmet fracture. So it's obviously a hard blow. There was no confusion, no amnesia. Now the patient is having headache, which increases with coughing. What is the most likely diagnosis in this patient? So what do you think? If a patient has a fall 1 week ago and now the patient comes to you with headache, which increases with coughing, which means that there is raised intracranial pressure already. That's why, like if you have a raised ICP, if you bend over, if you give cough, if you do something like which can increase the pressure, like bending over, coughing, sneezing, it will cause more headache. And there will be early morning nausea, vomiting. That's usually your raised ICP characteristics. So this patient is having raised ICP. There is a helmet fracture. Now, what do you think? Intracranial hemorrhage, subarachnoid hemorrhage, extradural hemorrhage, subdural hemorrhage, concussion. Very important. Now, usually with this sort of like falling from the bicycle, having a helmet fracture, and then after a week patient presents with headache, should not be intracranial hemorrhage. If it was intracranial hemorrhage, it would be just acute presentation. Similarly, if it was a extradural hemorrhage, usually presentation is acute presentation. So if you look at this one, epidural hematoma, skull fracture from blunt trauma causes laceration of arterial vessels, most commonly the middle meningeal artery. So usually epidural hematoma means, you know, the meninges has 3 layers, right? So dura mater, arachnoid, and the pia mater. Now, above the dura is the epidural space. And above the dura, usually you have the arterial vessels, especially meningeal arteries. If you have any way, if you rupture or tear those meningeal arteries, patient can develop epidural hematoma. So it's an arterial kind of bleeding. Fracture usually occurs in the temporal bone. In contrast to the subdural hematoma, a tremendous force is usually required. Now, important is this triphasic presentation. Patient can have an initial brief loss of consciousness followed by a lucid interval, which means the patient will be totally fine. And then suddenly patient again comes to you with a headache, progressive confusion, and even hemiparesis. So this is called triphasic presentation of epidural hematoma. But remember, one important thing, that epidural hematoma usually presents acutely. Should be acute presentation, not a chronic or subacute presentation like this. There may not be any lucid interval, or there may not be any brief loss of consciousness initially, but obvious thing is acute presentation. But the classic presentation will be brief loss of consciousness followed by injury or fall. Then there is a like minutes to hour lucid interval of complete neurological normal, and followed by again neurological confusion, headache, and progressively patient goes to coma. So that's called epidural hematoma. If you look at here, this is the CT scan of epidural hematoma. Always, if you see that it's a biconvex kind of shadow. So that's called epidural hematoma. If you come to the subdural hematoma is a injury to the bridging veins in the dura mater. So subdural means below the dura mater, there are bridging veins. If you sustain a very tremendous force injury, it can injure those bridging veins, and then you can develop the subdural hematoma. Subdural hematoma can present acutely, subacutely, and even chronically. Usual presentation is subacute and chronic presentation. So if you see, in contrast to epidural hematoma, usually changes may be subacute or even chronic. If you look at the CT scan, usually it's called crescentic kind of shadow. Like it's a kind of crescent kind of shadow, right? So that's your subdural hematoma. So main thing to remember is, like, if it's patient presents to you with the acute presentation, always think it as extradural hematoma. If patient comes to you with a subacute presentation, then think it as a subdural hematoma. So our correct option will be D. Clear, everyone? Now, the next question, a elderly patient comes to you. So this is, I'm just asking a question related to that. So an elderly patient comes to you with forgetfulness for about a month, is getting worse. Previously, patient was not that bad. He is like 80-year-old patient. Now, patient presents to you with progressively worsening kind of forgetfulness and dementia for the past 1 month. Now, your options are like what you will be doing next, or what is your next most appropriate management for this patient. If any time in the exam they use the term next most appropriate, that means the next thing. If they ask what is the most appropriate, that means they are asking the confirmatory or the absolute treatment for this condition. Now, if I ask what is the next most appropriate thing that you are going to do, what should you do? Yeah, Dr. Faril, Dr. Dia, very good. This is also a handbook question. Very important to remember. Any patient, elderly, not or even young patient comes to you with a sudden onset of worsening forgetfulness or sudden confusion, anything like that, we should always rule out subdural hematoma, because subdural hematoma sometimes can even presence like months and months later on. So patient may not even know that he had a fall or he had just a small minor trauma to the head. So even if it was not causing any difficulty, but gradually worsening the forgetfulness. So anytime before you go for any more investigation or management of forgetfulness or dementia, always do the CT scan, rule out vascular dementia first, and then think about others dementia like Alzheimer's, frontotemporal, okay, or Lewy body. So anything, if you think, but first thing to rule out is vascular dementia if a patient presents to you with a worsening forgetfulness. Clear? You can go through this link from the Radiopedia, how to differentiate between extradural hematoma and subdural hematoma. It's a good link. Any question? Yeah, any Dr. Anika, right. Any next is initial investigation. Any next initial investigations they are asking. The next question is our genetics related. Very important, high yielding. And remember, I haven't talked with you about how the exam questions, usually the pattern of the exam question. I will discuss it in our first 2 weeks free sessions, how, how the exam questions are marked, how the questions are patterned in the exam. So we will discuss this more in those sessions. But just to remember, there are some questions which are mastery questions and they have like more marks. Like if you know or not, in the exam, there can have some questions containing 2 marks, 4 marks, 6 marks, 8 marks. So usually mastery questions, you have to pass those mastery questions if you want to pass the whole exam. So what, like genetics, some of the questions that we are discussing, it's usually these topics are mastery topics for any exam. Like if you go for any exam in your life, these are mastery topics you should know. So genetics is must to know, and if you usually answer it correctly in the exam, there is a more likely that you are going to pass those exams because you are going to get a good marks, and marks matter in the exam because you have to get at least 250 to pass this exam. So sometimes people will say that my exam was very easy, the questions were pretty good, but still I have failed. Why? It doesn't make like if your exam is easy, you will pass this exam. Even sometimes difficult exam easier to pass because difficult exam has more like high mark questions. If you get those questions correct, you pass the exam pretty easily. So genetics kind of is scary for many of us, right? But for after today's class, I don't think it will be scary anymore. So before I answer this question, I will discuss the pattern of genetic inheritance. Like you know that there is most importantly 3 inheritance. One is autosomal dominant, another is autosomal recessive, another is your X-linked recessive. The 3 things. Let's move here, or we can even do it here. First, we are going to do the X-linked. Sorry, we're going to do the autosomal dominant first. So for the purpose of easy understanding, I always keep it as the XY, but normally, usually XY is used for X-linked recessive. But you will see that if you keep everything as a XY and XX, it becomes very easy. So XY, you understand, is the male, XX is female. Now let's assume we are discussing the autosomal dominant pattern first. So it's AD. In autosomal dominant, if just one dominant gene is affected, the patient is diseased. So let's assume the male person or the father is the diseased person. So this is the defective gene he is carrying. Now always we have to make 4 possibilities. So there is XX. Now this one is again there is a XX. These two will lead us to XY prime. And there is another XY prime. Clear. So what do you think? This XX, it doesn't have any defective gene, so it's a normal. This XX doesn't have any defective gene, it's normal. So out of 100%, 50% is normal. And now this one has one defective gene. This one is also having one defective gene. So they are both diseased. So 50% is diseased. So that is your autosomal dominant. In autosomal dominant, usual mode of inheritance will be 50% of the children will be normal and 50% will be diseased. There will be no carrier in autosomal dominant. That's an important thing. There will be never ever any carrier state of autosomal dominance. Clear? Now let's do another important one, which is important for the exam, which is autosomal recessive. So again, XY, XX. Now remember, to be a diseased person in autosomal recessive, you have to have 2 genes containing the defective gene. So again, if you want to be defective or like a diseased person in autosomal recessive inheritance, you have to have 2 defective genes to express the disease. Now, if there is one defective gene, they are carrier. So let's assume this one is a carrier. That means father is a carrier and mother is a carrier also. And what they are carrying? Father is also thalassemia minor, mother is thalassemia minor. Okay. Now let's see what happens in their children. So we have got the first one as X prime, X prime. So this is X prime, this is X prime. Now let's do this one, X, X prime, right? Now this one, X prime Y. And there is another one, XY. So let's start with this one, XY. So no defective gene is totally normal. Then X prime Y, one defective gene. So this is a carrier. X prime, one defective gene, so it's also a carrier. X prime, so both, that means two defective gene, so is the diseased person. So 25% is diseased, 50% is carrier, and another 25% is normal. So that's one of the presentation of autosomal recessive. This is a very important in the exam. If they say that the parents comes to you to know that what is the possibility of their offspring to get the thalassemia major, both parents are thalassemia minor. So what will be the possibility of getting the thalassemia major? 25% of the children will be having a chance to get thalassemia major, 50% will be carrier, and 25% will be normal. All right, so that's your question. Clear, everyone, these two? So one of the, if I ask you to give some example of autosomal dominant, what you can give, one of the important is hereditary spherocytosis, pretty common. Thalassemia is very common in case of autosomal recessive. Now let's go for, yeah, Huntington disease for autosomal dominant. Let's do this one. So we just left with one, which is X-linked recessive. Sorry. For X-linked recessive, what we should do, again, XY, XX. So remember, it's a X-linked recessive. As the for a recessive disease, at like in here, obviously the X should be affected. All right, as the name is X-linked, the sex chromosome should be affected in here. That's the main thing. Let us discuss, like let's assume that mother is carrier. The main thing in X-linked recessive disease is most of the time the father is affected, or the male person will be affected, female person will be carrier most of the time. And female gives disease to the son, or mother gives disease to the son. Let's see what happens in here. So we got XX prime. We have got XX. We have got X prime Y. And we have got XY. Right. Now this one is normal, right? In here, X prime Y. All right, let's just do the normal one, XX normal. XX prime. Remember, what happens in X-linked recessive? This one is defective, but the another X will counteract the other defective gene. So there will be no expression of the disease in here. This one will be a carrier. As I said, female, XX means female. So female is always carrier. In most of the time, they are carrier in X-linked recessive. So you have got 25% as a carrier. You have got 50% normal. And now this one, X prime Y. What do you think? This patient, the X is defective, but he doesn't have another X to counteract that defective gene. So he will get the disease in here. So that's why usually the male person are the diseased in case of X-linked recessive. And obviously mother gives the disease to the son. No, never ever to the daughter. Okay, so you have got 25% diseased also. So 25% carrier, 50% normal, 25% diseased. That is your X-linked recessive. Is it clear, everyone? Good. See this one. There is sometimes they can give you the Mendelian pattern and then they can ask you that what is this pattern. So if you remember, very important clue will be every generation has the disease and there is no carrier state that's always will be autosomal dominant. Okay, so the 2 point, every generation having the disease and there is no carrier that's autosomal dominant. Pretty easy to find it out in the exam. But if not every generation having the disease and also there is carrier state, it could be either autosomal recessive, could be X-linked recessive. How you can find it out? You have to look at if the father is giving the disease to the son or not. If father gives the disease to the son, that is autosomal recessive. Father doesn't give the disease to the son, that is X-linked. Just now we have seen in X-linked recessive, mother will give it the disease to the son, not the father. So if you see there is generation skipping, there is carrier state, think it could be autosomal recessive or X-linked recessive. Then you look at if the father is giving the disease to the son or not. If father is giving the disease to the son, that is autosomal recessive. Father not giving it to the son, mother is giving it to the son, that is X-linked recessive. X-linked recessive is usually hemophilia is one of the important diagnosis. Now let me see this one. We have already discussed those. Now this is your Mendelian inheritance. Tell me, what do you think? Is it dominant or recessive? If recessive, then what recessive? So for your purpose, let's see that this is the father and this is the mom. So what you look at in here is that father and mother. Now these are the four offspring we can see. Now I can see that this box is for male, and that means the rectangle is for the male, or a square is for the male, and circle is for the female. Now look at the square. One square has got the disease. That means son has got the disease. 50% is normal, and this one is the carrier, right? One daughter is carrier. Now what I look for here, I can see that in here, if you look at the next generation, so this is the next generation. So one of the daughter was married with one of the affected person, and one of the affected son has married with a normal female. Okay, and there is in here there is no generation skip in this case. But if you look at this in here, if the affected son marrying an unaffected, a totally normal female, and you know that usually father will never ever give the disease to the son, right? and female will be carrier. So if you look in here, this generation will be skipped generation. There will be no diseased person. So even you don't need to look at this one. If you just look at this pattern, it's pretty easy to find out. Now, if you are confused, then look at the generation. See that in here, one generation is skipped. Now, generation is skipped. Then you look for, did the father gave the disease to the son or not? If you look at here, father was normal, mother was carrier. So father did not give the disease, mother gave the disease to the son. Again, this one was diseased, and the next, that maybe that the son has married another female who was normal, and the father did not give the disease to the son. Son is normal, right? So that's usually what we should think about at that time. We should think about X-linked recessive. So generation is skipped. Look at the father giving it to the son or not. If father doesn't give it to the son, it's X-linked recessive. And even if you don't look at the generation, it's pretty easy how, because if you look at here, father is normal, mother is carrier. And then what happens in here? Mother gave the disease to the son. And female is only carrier, not diseased. So that's usually the main two criteria of X-linked recessive disease. So what will be there? Female always carrier. Can you see any female in this genetic pattern having the disease? No. No female is diseased. All of them are carrier. It's an important clue. And we can only see that the male person are affected, and male is getting the disease from the affected mom. Now, maybe some of you who are thinking more, you can ask me a question that why this son has got the disease. Because you see that in here there is a thing that mother is carrier, father is defective. If you do the math, you will find out that in that time there is a possibility that father can give it to the son, just only if the mother is also a carrier at that time. Otherwise, never ever a diseased father with a normal female never ever give the disease to the son. It's a little hard, but can you guys understand me or whatever I am saying? If you want, I can repeat it. This one is like, this is called applied genetics. What we have done previously, it was just a basic. Now this one is your applied genetics, which is hard. And if you just if you know the basic of genetics, then only you will understand it. Any question from these genetic patterns? We will do more of it, and also like we will have exam questions in the software. We have a software similar to the exams. So what we will be doing, we will give you these questions from the genetics and we will ask you to solve those things. So it will be easier then, like with multiple solving of these sort of things, you will be pro in it. Don't worry. Okay, let's move to the next one. A lady comes to you with weakness of lower limbs. So there is weakness of lower limbs. She drags her foot while walking. So there is dragging of the foot. Dorsiflexion and plantar flexion is weak. Reflexes are exaggerated. Equivocal plantar response. What is the diagnosis? Tell me one thing, what you are finding in here. So anytime there is a nervous system question, what we look for is it an upper motor neuron lesion or lower motor neuron lesion? Weakness of lower limbs, that's one thing. Dragging the foot, that means foot drop, is usually lower motor neuron presentation. Look at the flexion, dorsiflexion and plantar flexion is weak. So this is also peripheral muscle problem. So that's also lower motor neuron. Reflex exaggerated, that's upper motor neuron, right? And plantar response is equivocal. So it's not, this one is also usually not for upper motor. Now what you find out in here, there is both upper motor neuron and lower motor neuron type of lesion in the same limb. This is the clue. Anytime in the exam, in the same limb, that means like in the right or left leg, there is both features of upper motor and lower motor neuron type of lesion. That's your MND or motor neuron disease. Okay, so look at the upper motor neuron type of lesion. Upper motor neuron type of lesion means usually it will affect from your cortex. So from the cortex up to the anterior horn of the spinal cord, this part is the upper motor neuron type lesion. Anywhere there is lesion, it will cause upper motor neuron type of lesion. Most importantly, they will present with hemiplegia, spastic hemiplegia or paraplegia. There will be rigidity, hyperreflexia, and plantar will be upgoing. In lower motor neuron type of lesion, the most common presentation is weakness and distal myopathy, or usually mainly the weakness of the lower limbs and wasting of the muscles will be the presentation. The tone will be hypotonia, not hyper. Hyper will be upper motor. Reflex will be absent. There will be fasciculation, and plantar will be absent. That is lower motor neuron lesion. Lower motor neuron lesion is any lesion from this anterior horn of the spinal cord up to your muscle. Okay, so in your exam, you find out there is weakness of the lower limb. There is like this dorsiflexion, plantar flexion. That means distal myopathy is there. So this is lower motor neuron, but the reflex is exaggerated, which is upper motor. So both upper and lower motor neuron lesion in one limb, that is motor neuron disease. Let's just give an idea that what about the other option? Cervical spine myelopathy. If it is a cervical spine problem, where will be the main problem? Is it in the limb or also in the upper limb? So if it's a cervical spine problem, you will get some finding in the upper limb also. Okay, so in here there is no upper limb involvement, so it's unlikely. Spinal canal stenosis. If you remember, usual presentation of spinal canal stenosis is bilateral. So usually you will get bilateral upper motor neuron type of lesion. In here is just usually like in here you have got upper and lower motor neuron both. In a spinal canal stenosis, most of the time you will get bilateral upper motor neuron type of lesion. Lesion in the cerebral cortex. Now this one is a vague option, I would say, because motor neuron disease also can be in the cerebral cortex. If the motor neuron in the cerebral cortex is involved, that's also, like it's a motor neuron disease is also a subtype under this D. But the B option is more correct and more precise, so that's why we will choose that one. Clear, everyone? So this is how you should exclude the other option and find out your most appropriate answer. So now we are going into the nerves. Before we go into the nerves, so just to give you an idea, now the most difficult part we will start. So we will do the lower motor nerves problem. We will do upper motor nerves problem. Yes, if you select D, it is wrong. This exam is selecting just a one most important answer or one most appropriate answer. So if you select D, it's wrong. There is never ever two option which is correct. Only one option is always correct. So let's take a 5-minute break before we start this nerve. So we will do radial nerve injury. We will do L5S1 sacral nerve problems, lumbar problems. So this will be our next thing after the break. So don't go anywhere. Just take some drink or coffee, and then we will come back in 5 minutes time. Thank you all. Okay, everyone. So let's start again. So we've got our next question. So 58-year-old man dragging the left foot, reflex on the left lower limb are increased. So it's the same question like we discussed in the previous one. You can see there is dragging of the left foot, which is problem with the dorsiflexion. The reflex on the left lower limb are increased, right? So hyperreflexia. Plantar flexion, dorsiflexion are weak. There is equivocal plantar reflex. Upper limb face are normal. What is the site of the lesion they are asking? Now, if you see in this case, again the same thing, there is dragging the left foot, the distal muscle is weak, which is lower motor neuron type of lesion, but reflex are exaggerated. So in the same limb, there is both upper and lower motor type of lesion. So what do you think is the lesion site is? Is it a common peroneal nerve? Now, common peroneal nerve can cause problem with dorsiflexion and eversion. So how we remember common peroneal nerve? ED. ED means emergency department, right? So E for eversion and D for dorsiflexion. Common peroneal nerve is a peripheral muscle. Sorry, common peroneal nerve is a kind of peripheral nerve which usually will give your main supply will be doing the dorsiflexion of the foot and eversion. But it will never ever give a upper motor neuron type of feature because it's always a lower motor neuron. Remember, the peripheral nerves are always lower motor neuron. So if the reflex exaggerated or increased, it will never ever be a common peroneal nerve. Cervical spinal cord, again, it should be most importantly, the upper limb should be affected, not the lower limb. L5S1 nerve root, if it was a L5S1 nerve root, again it should have like a lower motor neuron type of palsy, and usually the presentation will be a kind of sciatica like feature, not both upper and lower motor like this. And L5S1 nerve root problem usually will cause problem with dorsiflexion, inversion, eversion. Three things: dorsiflexion, inversion, eversion, not the plantar flexion. Cerebral cortex and brainstem. Brainstem, like if the brainstem is affected, usual presentation is like kind of a stroke-like feature. But other important is like having a nystagmus, having dysarthria, having worseness of voice, okay, having Horner syndrome, having some dysphagia. So usual presentation will be dysarthria, dysphagia, those sort of nerve like cranial nerve 9, 10, 11 will be affected more if it's a brainstem problem. So it's unlikely this one will be a brainstem. As I told you previously that cerebral cortex contain motor neurons. And if the motor neurons in the cerebral cortex are affected, it can give you a motor neuron type of disease. So that will be our site of lesion in here. And you can see there is no sensory loss in motor neuron disease, only the motor problem. So L5S1 nerve root, usually it will give you a sciatica kind of feeling. What is sciatica? Your L5S1 nerve root is irritated and patient usually gives like there is a shooting kind of pain coming from the back going down to the foot, usually one side of your leg, like right or left. And they usually doesn't have any problem with the reflex. So usually L5 doesn't give any reflex. It can give S1, can give ankle reflex. So ankle reflex will be absent in that time, but in here all the reflexes are exaggerated, so it's unlikely. And the muscles it give the supply is dorsiflexion, inversion, and eversion, three things. But in here it's the plantar flexion and dorsiflexion which is weak. Clear, Dr. Farid? Good. Let, now let's do this CVS risk chart. CVS risk chart is very important. It's a kind of like mastery questions in the exam, and more mark in this graph like questions. Possible chances that the exam question usually you will get more marks if you answer it correct. The CVS risk chart, this is the chart they will provide to you, and you have to find out what is the risk of 5-yearly cardiovascular disease in this patient based on the parameter that will be given to you. Now, if you look at this chart, this is the chart for people without diabetes. This chart is for women, and this graph is for men. And then it's non-smoker, smoker. In the y-axis, there is systolic blood pressure. And in the x-axis, there is total cholesterol and HDL ratio. So this information will be given in your exam. So you've got your age of the patient, which is a 64-year-old smoker woman with a blood pressure 135. So we need the systolic blood pressure only. And cholesterol HDL ratio is 6.6:1. And she's a smoker. So what we are looking for, 64-year-old woman who is a smoker. So this is the woman. This is the smoker. Now 64-year means this part we are looking for, right? Now we need to find out what's the SBP of the patient. The SBP is 135. Now, before I put SBP and HDL cholesterol ratio in here, I want you to know what each of these cell contains. If you look at here, this is 120, 140, 160, 179, right? If I ask you what is the maximum SBP will be fall in this cell. So in this cell, how much SBP you can fall or you can put on. Remember, this cell contains up to 130 SBP, not 120. This is a very common mistake most of the students do. But remember, always this 120 is not the maximum, 130 is the maximum. Then the next one is 150, next one is 170, then 190. Clear, everyone? Now, what if 130 is the SBP? Will you put on here or here? Always remember, if it's a marginal, we go to the above. So it will be here, in the second box. Clear? Now, this one is for SBP. What about your total cholesterol HDL ratio? For total cholesterol HDL ratio, you can see 4, 5, 6, 7, 8. Now, what this cell will contain? Remember, it's not the 4, it's 4.5 is the maximum of this cell. Then this cell is 5.5, 6.5, 7.5, and this cell contains 8.5. Now you will say if it is a systolic blood pressure 135 and cholesterol HDL ratio 6.6:1, where you will fall this women. If you look at here 135, which box will be? Obviously this box we are looking about, right? Because 130 will fall up to here. From 130 to 150 is the second cell. Now you come down, that is a 6.6. So 6.5 will be up to this box. Now 6.6 will fall into the fourth box. Go up. If you go up, so this is our cell, right? So this is the yellow. So yellow cell is our answer here. Now we have to see in the chart, they will give it to you. What is the percentage of CVD risk for yellow chart? Let me Let me show you the guideline from Australian Heart Foundation. So this is the Australian CVD risk chart, you can see. Now, if you look at here, they will give it to you. These are the high risk color, moderate risk color. This is low risk color. Our patient is having yellow. So what will be the risk? 16 to 19%. And that will be your answer. If you just want to be confirmed, you see in here, this is what I was talking about. For example, the lower left cell contains all non-smoker without diabetes. So see, lower left cell contains non-smoker. So this is the non-smoker and no diabetes who are 35 to 44-year-old, right? Have a total cholesterol HDL ratio less than 4.5. So this is the lower left cell they are talking about. And it contains up to 4.5. And SBP of less than 130. So SBP will be up to 130 maximum in here. So less than 130. So if it's 130, it should be in this box, second box. Clear everyone? This is the guideline we should follow in this question. Many candidates will never ever know this one and they will do incorrect. Make sure after this class, you guys don't miss it if it comes in your exam. The next one is one of the important topic that we are going to discuss. Okay, upper limb neuropathies. If you see this one, the patient in here had a stab wound to the back of the left forearm in a pub brawl. He's trying to straighten his fingers on command. Now, this patient had an injury to the left forearm. Now, patient is unable to straighten the finger, but he's able to straighten the wrist, you can see, right? So wrist is good, but the problem is extension or straightening of fingers. They're asking what nerve is most likely to have injured. Median nerve, ulnar nerve, radial nerve, posterior interosseous nerve, anterior interosseous nerve. To understand these, you have to have a very good idea on upper limb nerves. So upper limb, most important three nerves are median nerve, ulnar nerve, and radial nerve. Remember, this is the dorsal aspect of your hand. Your dorsal surface always given by the radial nerve. And or you can keep it as a plantar aspect, right? So your plantar aspect, or you can say it's a like pronator aspect, keep it as a dorsal, that will be easier. So this is dorsal aspect and the another one is the palmar aspect. For dorsal aspect, always it will be given by the radial nerve and the palmar side will be given by ulnar nerve and median nerve. We are not going to discuss ulnar nerve, radial nerve, ulnar and median nerve tonight. We are going to discuss about a very important nerve, which is radial nerve. Now, radial nerve can be injured in many places. First of all, let me just show you radial nerve course. So this is how the radial nerve course looks like. Let me just take it from here so that you guys can understand pretty well. Okay, so let's see this one here. Before doing any nerve, remember guys, always see the course of the nerve, that from where it comes and where it gives supply. Now you can see it runs through your brachial plexus. Now from your, this is the humerus. This is called spiral groove of the humerus. So from the spiral groove of the humerus, the radial nerve goes from here and it gives supply to the dorsal aspect of your hand. It has a branch called posterior interosseous nerve, and also it has a superficial branch of the radial nerve. So this is how the radial nerve actually gives supply to your dorsal aspect of the hand. So it can be injured anywhere. It can be injured in the axilla. It can be injured in the shaft of the humerus, can be injured at the elbow, can be injured in the wrist. So we need to know what will be the presentation and where will be the site of injury. If the injury occur at the axilla, what will be the presentation? If it injured at the axilla, that means the whole radial nerve will be affected. So it will give motor deficit. Now remember, radial nerve gives what are the motor function? One is extension of your forearm. That means your forearm extension, then supination, and extension of your hand and finger. Mainly remember these two, extension, everything will be extension in radial nerve. So extension of your forearm, or you can just keep it that extension of your elbow, extension of your wrist, okay, and extension of your finger. Now, if you cannot keep extended of your wrist, so what will happen? Your wrist will fall, right? And that is called wrist drop. If you can keep your finger straight or extended, your finger will drop, which we call finger drop. So wrist drop, finger drop, always a presentation of radial nerve injury. So what will happen if it's injured at the axilla? Not only the wrist drop and finger drop will be there, also there will be loss of extension of the forearm. That is an important finding if it's injured at the axilla. Sensory deficit, your radial nerve gives supply to the usually radial 3.5 digit. What is radial 3.5 digit? If you look at here, your thumb, that means these three finger, thumb, index finger, middle finger, this will be given by the radial nerve. So importantly, this part, radial 3.5 finger will be given by the radial nerve. And this part will be given by the ulnar nerve. So why will be the sensory loss? So your loss of sensation, because if you just remember the course, so it gives supply to whole area. So your loss of sensation will be in the forearm, then loss of sensation in these three fingers. So all sensory loss will be here if it injured in the main point, which is at the axilla. So if injured at the axilla, motor problem will be extension of the forearm, extension of the wrist, extension of the finger. Clear? And this will be the sensory deficit. And you can see this is the radial nerve territory, this is the ulnar nerve territory, and this is the dorsal aspect. In the palmar aspect, this three finger is given by the median nerve and this given by the ulnar nerve. Now you have got it in the axillary region if the radial nerve is injured. What if the injury is at the mid-arm? If you remember, the mid shaft of the humerus can be fractured many times. So if there is a fracture of the mid shaft of the humerus, then what will be the presentation? Everything will be same like before, but the only difference will be in the sensory loss. The sensory loss will be only in the finger, that means radial 3.5 finger, but there will be no loss of sensation in the forearm or arm. So the motor loss will be similar, like in the axillary region, but sensory only will be in the fingers, not in the posterior forearm or arm. So that's only difference. Not very important. It doesn't come in the exam in this way, but if you are in a, like sometimes they can give you a radial nerve injury features and they are asking to you where the nerve has injured, in the axilla, in the mid arm. So at that time, remember, axillary or mid arm injury is same in the motor part, but sensory part will be a little different. If it's injured in the mid arm, or if there is a fracture of the shaft of the humerus, then only the finger sensation will be lost. No loss of sensation in the arm or forearm. Just below the elbow. So now comes to the elbow. If it injured at the elbow region, what will happen? Injury to the elbow injures the posterior interosseous nerve. Remember the posterior interosseous nerve? So if it and this is the site, right? So posterior interosseous nerve will be injured if it is injured at the elbow region. If posterior interosseous nerve is injured, remember this is the exclusively motor nerve. It doesn't give any sensory supply. So no sensory loss, and only problem will be loss of extension of the finger. So it gives finger extension only, nothing else. This is the only supply the posterior interosseous nerves gives. So if the posterior interosseous nerve is injured, usually the injury occurs around the elbow or below the elbow, and patient will have problem with extension of the finger, but wrist extension will be fine. Clear? What if it injured at the distal forearm or around the wrist, like distal region? Usual cause will be a stabbing or laceration of the forearm, resulting in injury to the superficial branch of the radial nerve, which is entirely sensory. So if there is injury at the distal forearm around the wrist joint, usually it will injure the another branch of radial nerve, which is the superficial branch I have shown you. Remember this one? This superficial branch will be injured around here. And this superficial branch is only sensory. It doesn't have any motor. So there will be only loss of sensation in the radial 3.5 disease. Clear? Pretty easy, right? So let's just recapitulate. If the radial nerve injured in the axilla, there will be motor problem. So loss of extension of the forearm, loss of extension of the wrist and the finger. Sensory loss to the forearm, arm, and the 3.5 finger. If it is in the mid arm or shaft of the humerus fracture, motor loss will be same, but sensory loss will be only in the finger. If it injured around the elbow, posterior interosseous nerve will be affected, which is entirely motor, gives only finger extension. So there will be only finger drop. If it's around the distal forearm, only the superficial branch of the radial nerve will be injured, which gives only sensory branch to the radial 3.5 finger. So you will only get sensory loss, no motor loss. Pretty easy. Now, what do you think this question answer should be? What do you think? So if you see in here, this patient has a stabbing wound to the forearm. Now trying to straighten his fingers, which obviously he is unable to do the finger extension. So what's the injury is? Is it the median nerve? No. Ulnar nerve? No. Obviously radial nerve. Could be posterior interosseous also because it's a branch. Anterior interosseous is a branch of median nerve, so unlikely. So between C and D, which one you will choose? Obviously we will choose the posterior interosseous nerve, right? Because only problem in here is the finger extension. So where is the site of injury? Below the elbow. Good. I think this is clear for everyone. Let's move to the next one. So you remember, guys, this is very, very important, high yielding topics for the exam. And you see, it's not very scary. I know that most of you was struggling for this sort of nerve related injury. We also have ulnar nerve injury. All those will be discussed in the class. No worries. Now the next one is your lumbar neuropathy or lower limb neuropathy. If you see in here, this is the MCQ 2.132, but still you will find that it's pretty hard to understand from what is discussed in the handbook. Look at the question. 64-year-old woman complains of dragging her right foot, numbness and paresthesia in that leg. There is foot drop with weakness of dorsiflexion, inversion and eversion of the ankle. The reflexes are normal and there is loss of appreciation of pinprick, so loss of sensation on the outer side of the lower leg. Which of the nerve root or nerve is most likely the cause of her presentation? L4 nerve root, L5 nerve root, superficial peroneal nerve, tibial nerve, sciatic nerve. So we have to know all these nerves if we want to really answer this question. So let's discuss first and then we will come back to this question. Let me show you something, a video, how it actually can. Now, remember in the YouTube, you can search for the course of these nerves and arteries. Usually these are very good. So let's see that what's given for the common peroneal nerve. Now I want you to look at here. So what do you see? This is called your lumbosacral plexus. If you look at here from L4 to S3, this actually comprises the lumbosacral plexus, and from here the nerve root actually goes downwards in your leg. These nerve roots, all of them combines together and creating the sciatic nerve. Now the sciatic nerve, when it goes downwards, it divides into common peroneal nerve and tibial nerve. Let's see if it's been shown or not. So you see that from here, it goes down through the back of your hip and the back of your thigh. So it goes down here And then in here, it divides into two parts. One is common peroneal, another is tibial nerve. This one, which one is going down to your calf? This is your tibial nerve, and which is going forward through the neck of the fibula, that is your common peroneal nerve.
And tibial nerve.
See?
The common peroneal nerve travels anteriorly around the fibular neck and divide into the superficial and deep peroneal nerves.
So I want you to know more about the common peroneal nerve. So you see the common peroneal nerve coming down through the neck of the fibula, and in here is divided into deep peroneal nerve and superficial peroneal nerve. Going into the forward, if you see in here, this is the superficial peroneal nerve giving most of the supply to the dorsum of your foot, also the whole front part of your leg. And this deep peroneal nerve is usually gives supply only in this region. Okay. That's all actually you need to know about it. So you have got like, so from the lumbosacral plexus L4S3, then they both, all the nerve root combines together, gives the sciatic nerve. Sciatic nerves goes down to the back of your thigh, and around the knee joint, it divides into tibial nerve and common peroneal nerve. Common peroneal nerve comes forward and it gives two branches of deep peroneal and superficial peroneal. Remember, the superficial peroneal gives supply to the whole front of the leg. Deep peroneal only gives this area, which is the first interdigital space. Now, let's start with one by one. Okay, so if it's a sciatic nerve, how it will present? Sciatic nerve will give supply to everything, right? So first of all, let me give you how the common peroneal nerve should present. If you have common peroneal nerve injury, your main problem will be, remember ED, emergency department? So your problem will be in the eversion, dorsiflexion. If you cannot do dorsiflexion of the foot, you have foot drop. Now, remember the common peroneal has two branch. One is deep peroneal, another is superficial peroneal. So you can see it's in the option, superficial peroneal. So deep peroneal will give dorsiflexion, D for deep. And the superficial peroneal will give eversion. So eversion is given by superficial peroneal, and deep peroneal will give the dorsiflexion. So first of all, we need to know common peroneal. It gives eversion and dorsiflexion. Now divide it into two. D for dorsiflexion, so, and also deep peroneal. So deep peroneal gives dorsiflexion, superficial peroneal gives eversion. And you know the supply, superficial peroneal will give the whole front of the leg, like your all the front part of the leg, like this one will be given by the superficial peroneal. Deep peroneal will be only this yellow portion. So we know about the common peroneal nerve, we know about superficial peroneal and deep peroneal nerve. Obviously, this C option is not correct because this patient is not only having problem with dorsiflexion, it also has inversion, eversion, everything. So it's not actually the common peroneal nerve injury, maybe something more. So we cross C. Remember the tibial nerve? Tibial nerve is a branch of sciatic nerve, right? Now this tibial nerve goes down to the back of your cuff, right? So in the back of your leg, tibial nerve gives supply. Tibial nerve gives just the opposite of common peroneal nerve, which is inversion and plantar flexion. So IP. If you have seen the movie called Ip Man, then you can easily remember that. So tibial nerve is IP, inversion and plantar flexion. So this one option is also incorrect based on the presentation of my patient. Remember one thing, the peripheral nerve, like common peroneal nerve, tibial nerve, they don't involve the reflex. Reflex only get exaggerated in case of either nerve root problem or upper motor neuron problem. Never ever any peripheral nerve like common peroneal, superficial peroneal, deep peroneal, tibial nerve, never ever it involves a reflex. So reflex will not be affected. So CD is crossed out. Sciatic nerve, it gives supply to the common peroneal nerve, it gives supply to the tibial nerve. But sciatic nerve is a peripheral nerve, it should never ever involve the reflex, and also sciatic nerve gives supply to the whole leg, not only on the, if you see, it's only the outer side of the lower leg is involved. If you know the dermatome, now we need to look at the dermatome also for this case. All right, let's just stick to here. I just want you to know that if you divide this part of the leg, this is the medial part and this is the lateral or outer part. Your medial part or the inner side of your lower leg is given by the lumbar 4 and the outer side is given by the lumbar 5. Above the knee joint is the lumbar 3 and in the thigh you have got the lumbar 2. So thigh lumbar 2, above the knee lumbar 3, inner side of the leg lumbar 4, outer side of the leg lumbar 5. So if you look at the question, it only has loss of sensation on the outer side of the lower leg, right? So it's not a sciatic nerve also. So we have crossed out sciatic nerve, we have crossed out tibial nerve, we have crossed out superficial peroneal nerve. Now the lumbar 4 nerve root, it gives supply to the knee jerk. So obviously, if it was a lumbar 4, what will be the loss of sensation in the medial side of the inner leg or inner side, not in the outer side? And obviously, the knee jerk will be lost. So lumbar 4 is not our answer. You see that reflex normal and the sensation is in the outer side. So it's not the case. So remaining option is lumbar 5. It's your answer by exclusion also. But remember, lumbar 5 doesn't give any reflex. So reflex will not be affected here. Lumbar 5 gives supply to the outer side of the lower leg. That's also here. And lumbar 5 gives three things. One is all of these, like dorsiflexion, inversion, and eversion. So you can see the mnemonic DI. So DI is for lumbar 5. So ED for common peroneal nerve, IP for tibial nerve, DI for lumbar 5. Pretty easy, right? You should never ever forget what I have just shown you. So if you just remember what I am saying, it will be easier in the exam. Very important, guys, these things to get it, because you will never ever get an absolute idea even after reading a lot of articles, a lot of things in the Google. The whole things to repeat. Who actually asked this one? Mnemonics, yeah. The mnemonics, first of all, your common peroneal nerve is ED, emergency department. So E for eversion, D for dorsiflexion. So dorsiflexion is given by which branch of the common peroneal nerve, guys? Anyone? Dorsiflexion will be given by which branch of the common peroneal nerve? Remember D for deep peroneal, right? So deep peroneal will give dorsiflexion, and eversion will be given by superficial peroneal. So ED is for common peroneal, which is eversion dorsiflexion. Common peroneal divides into two parts: superficial peroneal, deep peroneal. Deep peroneal gives this D dorsiflexion, superficial peroneal gives eversion. That's called common peroneal. Tibial nerve gives IP. For IP is inversion and plantar flexion. Okay. And your lumbar 5 nerve root gives DI. DI for dorsiflexion, inversion, and eversion. Clear, everyone? Yeah, you can also write it as a tip. Yeah, tip seems more easier, right? So you can, if you write is tip, tibial nerve gives inversion and plantar flexion. All right, I think that's a very good one for all of you. Let's move to the next one. So we will finish with the pneumothorax management tonight, and that will be our last thing tonight. I kept many things which are very important for all of you, but I know that it must be very tiring for you to get all these questions all together into your head. So I'm not going to discuss more than that. So we will finish with the pneumothorax question, which is also important, like not only important, very, very important. For pneumothorax, what is pneumothorax? That means there will be collection of air in between the pleural space. Now we divide the pneumothorax mainly into, if you see here, we divide it into primary spontaneous pneumothorax and secondary pneumothorax. So primary spontaneous pneumothorax means there is no underlying lung condition. That means no history of asthma, COPD. Patient just present to you spontaneously with pneumothorax. And you know that how the pneumothorax patient presents with, usually a young, thin-builded patient just after doing some exercise presents to you with an acute severe shortness of breath and chest pain. You do the lung examination and you have found out that in the left lung, the expansion is reduced, breath sound reduced, But on percussion, there is hyperresonance on the left lung. So you already got your findings as a pneumothorax. You ordered a chest X-ray, and then they have given to you that it's a 15% pneumothorax. What will be your next step of management? Now we divide pneumothorax as a small or large based on the size. If size is less than 15%, it's a small pneumothorax. If size is more than 15%, it's a large pneumothorax. Okay, so now come to the primary spontaneous pneumothorax. That means there is no underlying lung condition. Patient just present to you with a pneumothorax spontaneously. Come here for it. If it's a small pneumothorax, that means less than 15%, with a minimal symptoms. Minimal symptoms means patient doesn't have that much shortness of breath or chest pain. So minimal symptom, and it's a small pneumothorax. We don't need to do anything, just keep the patient under observation. Even we can discharge the patient after like 2 to 4 hour observation. Patient feels good, they can go home. So for a small pneumothorax with minimal symptom, just observation. What if it's a large pneumothorax, that means more than 15%, but there is no symptom? Remember, if it's a large pneumothorax, that means more than 15%, with or without symptom, we will start with the oxygen, because oxygen helps with reabsorption of the air that's collected in the pleural space. So if it's a large, that means more than 15%, we will give oxygen. Obviously, we will keep the patient under observation. Now, the most important one is large or small, but patient is having significant symptom of chest pain, shortness of breath. This patient needs immediate catheter aspiration or needle aspiration. All right. So previously we used to do the chest drain in this patient, but nowadays it's in your handbook and also in all the Australian guideline, we don't go for chest drain immediately. First try the catheter aspiration. Could be a needle aspiration, could be a pigtail catheter, whatever it is, we try the catheter aspiration. So we try with the catheter to drain the air that has been collected. Or usually it's called aspiration of the air, not a drain, aspiration of the air through catheter or through the needle. Now you do the catheter aspiration. What's your next thing to do? You will keep the patient under observation, see how the patient is improving. So in the next 2 to 4 hours, especially in 4 hours time, we do a repeat chest X-ray. If in the repeat chest X-ray after 4 hours, it shows more than 15% pneumothorax, also patient is having significant symptoms, that means patient is not improved, this patient will need chest drain. Another indication of chest drain will be if more than 3 liters of air aspirated initially when you did the catheter aspiration. So in these two situations, we will do the chest drain in primary spontaneous pneumothorax. So let's recapitulate this one again. If it's a small pneumothorax, minimal symptom, just observation. Large pneumothorax, minimal symptom, oxygen. Large or small, significant symptom, catheter aspiration, needle aspiration. If more than 3 liters air aspirated initially, go for chest drain. Do the chest X-ray in next 4 hours. See the size of the pneumothorax. If it is still more than 15%, go for chest drain. Still patient having significant symptom, go for chest drain. Is it clear to everyone? Now let's go for the secondary pneumothorax. What is secondary pneumothorax? Secondary pneumothorax means that patient is having some underlying lung condition. The underlying lung condition, most likely asthma, COPD, tuberculosis, any lung condition, and patient presents to you with a pneumothorax that fall under secondary pneumothorax. Important thing to look in secondary pneumothorax is what is the age of the patient. If the age is more than 50 or not, size of the pneumothorax, like if it is more than 15% or not, and what is the symptom of the patient. Any of it, like patient is having significant symptom, patient age is more than 50, or size of the pneumothorax more than 15%, we need to go for immediately chest drain. So what I have said, any of the symptom, like significant symptom, patient age is more than 50, or patient's size of the pneumothorax is more than 15%, we have to go for chest drain, not a aspiration in here. But there is a possibility of needle aspiration just in one case. If the age is less than 50, patient not having significant symptom, and size of the pneumothorax is less than 15%, we go for an aspiration at that time. Clear? After aspiration, if not improved, then you can go for chest drain. So if you look at this here, needle aspiration and review, if no significant symptom, size of the pneumothorax less than 15%, we do the needle aspiration. Catheter drainage or chest tube drainage, patient symptomatic, size of the pneumothorax more than 15%. Also, if the patient age is more than 50, we have to go for chest drain. Clear, everyone? Now we will go for our question. Now you tell me what's your answer in here. And is it a primary spontaneous or secondary spontaneous pneumothorax? Primary means there is no underlying cause. Especially it usually occurs like if over the pleural surface, there is some superficial blips, like some air sacs that gets ruptured, gives you the primary spontaneous pneumothorax. So what do you want to do in here? Let's see that 15% pneumothorax. So it's in the marginal. In marginal, we always select the next appropriate thing. See, young person with asthma. So there is underlying lung condition. So it's a secondary pneumothorax. There is no role of observation in secondary pneumothorax. So let's just omit E. Let's omit D. Let's omit B. So just excluded with this thing, B, D, and E. Now, what you will do? Do you do aspiration or chest drain? See in here, it's a young man, so not more than 50 years. It's a 15% pneumothorax, not that much large, and patient doesn't have any symptom. Saturation is good. What do you want to do? If it was 25% pneumothorax, I would go for chest drain. Now for a 15% pneumothorax in a young person not having any symptom, let's start with aspiration. Clear? In here, now see that it's a marginal one, right? In here, you have to use your clinical judgment that what we have got. We haven't got any significant symptom. We haven't got that means it's a 15%. It's in the margin of small and large. That's usually one confusion. But let's see that symptoms, no symptom. Patient is a young person. So in here, we can just start with the aspiration. We don't need to go for a chest drain with no symptom, and also it's a not more than 50 years patient. Okay. So in the exam, it can get confused because I know that 15% pneumothorax is a marginal. We would, like, according to that flow chart, we would go for a chest drain, but it's not more than 15, it's a 15. If it's a 15, then we think that Is it a more than 50-year-old person? No. Is this patient is having significant symptom? No. So no need of doing a chest drain. Chest drain is an invasive thing. It's a very painful thing for a patient. So let's start with the aspiration in this patient. What if this patient 15% pneumothorax and patient age was 57? At that time, we would not go for aspiration. We would go for chest drain. So it's a clinical judgment you should also sometimes you have to follow. Suppose if this patient is primary pneumothorax, for a 15% pneumothorax with minimal symptoms or no symptoms, what we would do? For 15%, that means, remember, for more than equal 15%, we can give a oxygen if it's in the option. If oxygen not in the option, then just admit and observe. Why I am saying oxygen? Because in your handbook, there is a question with pneumothorax, and it's written in here that oxygen can be given in case of more than 15% pneumothorax with a minimal symptom, because oxygen helps in reabsorption of air. So in this question, if it was a patient did not have any asthma, 15% pneumothorax with minimal symptom, in here, yes, we can give the oxygen first, not observation. If it was less than 15%, no symptom, then observation. Just see the chart again. So see, if it's a small, that means less than 15%, then observation. Large means more than equal 15%. With minimal symptom, we just give a oxygen first, and also we will keep the patient under observation. What if I'm giving you a scenario, a patient, 50-year-old patient comes to you with shortness of breath, chest pain. Patient has infective exacerbation of COPD, and you have diagnosed the patient with a pneumothorax of 10%. So 50-year-old patient with a history of infective exacerbation of COPD comes to you with a symptom of chest pain, shortness of breath, and a 10% pneumothorax. What's your answer? Yeah, chest drain, right? Because even if it's not a large pneumothorax, but patient is 50-year-old, patient has COPD, so secondary pneumothorax, and also significant symptoms. So go for drain in that case. What if a 15-year-old patient comes to you, okay, with a 10% pneumothorax, and patient is having oxygen saturation of 88% and complaining of chest pain? So 15-year-old patient, 10% pneumothorax, having an oxygen saturation of 88%. Also patient is having chest pain. What's you're going to do? So we will go for the, let's see which one this patient falls into. So this is a primary spontaneous pneumothorax, no underlying lung condition. So large or small, our patient is having 10%, but patient is having significant symptom, right? So what you're going to do? You're going to go for an aspiration. Now, what if it's in between oxygen aspiration? You will choose aspiration because this patient needs immediate aspiration. Even if you give oxygen, it will not help because this patient needs an aspiration immediately. If you do the aspiration, oxygen saturation will be okay. A patient, 15-year-old patient, comes to you with an acute severe chest pain with a shortness of breath, JVP raised, and apex bit shifted to the shifted to 15 centimeter away from the sternum. What's your diagnosis? 15-year-old patient comes to you with an acute severe chest pain with a shortness of breath, JVP raised, apex bit shifted from the up to 15 centimeter away from the sternum. Tension pneumothorax, right? So mediastinal shifting in a pneumothorax, obviously this is a tension pneumothorax. For tension pneumothorax, what will be your next step of management? The term we use is urgent needle decompression. Okay, so you have to do the urgent needle decompression in this patient. So I guess that this was all about today's class. We will not go further than that. I think this was helpful for all of you. These are very important topics that you will always have some difficulty. Any question from today's class? And just give you an idea. So we are going to start our 5 months course from 30th of May, right? So the initial 2 weeks will be totally free. So you guys you will see how our software works. You can appear some of the exams there. And also you will go for the some of the lectures that we can take in the first 2 weeks. And then you can decide that if you want to go for a course or not. I'm saying that it's not mandatory for everyone, but those of you who are struggling, who want to pass the exam as soon as possible, for you, course will be a beneficial things. We will be helping you with these important questions and also making your theory clear as fast as we can. So we will discuss both the questions and the theories, and we will make sure both of them are interconnected so that you know that why you are studying the theories, and then you will implement your theory knowledge into the questions. So that's the plan. All right. So that's all for tonight. And thank you so much for joining today's session. I think it will be helpful for all of you. And I will keep it as a recording in our group also, so that you can also listen if you need to. Thank you all. Is there any question from those of you who are in the Facebook? We don't have any exclusive class for recalls. Usually we don't have that exclusively. We do some practice questions with the theories. So that will be, so no exclusive class for recalls, I think. But with theory, we will do that. The next class will be on the 30th of May. Those of you are interested, give me a message in my messenger, or also you can write it in our official group. There are many details given there that where to contact everything. My email also given. So whatever you are, just make sure you give me a message if you are not still added. We have already added like 40 students maybe in the group. So if you're not still added in the course group where we will take the next class, so just let me know. All right, then thank you so much for joining today's session. Thank you all. Have a good night's sleep. Bye.